would like to present this talk on clinical care of drug-induced liver injury. In clinical trials, patients can have asymptomatic liver injury that is detected by monitoring, which, if it develops into severe injuries and associated with jaundice, this can lead to fatal outcome. In clinical practice, DILI is a very important differential diagnosis in all patients who present with abnormal liver tests without obvious etiology, and those with normal hepatobiliary imaging. In the labeling of several drugs, liver test monitoring is recommended in order to detect and prevent hepatotoxicity. For some drug classes, for example, for anti-tuberculosis drugs, this has been shown to be life-saving. Unfortunately, labeling can be different between countries even for the same drug, and compliance with monitoring of liver tests has been shown in several studies to be poor. What is called hepatic adaptation has been well characterized. That is, elevated liver tests can occur during drug treatment, which can normalize despite continuation of treatment. However, those individuals who have what it seems the inability to adapt to the metabolism of the drug or cannot develop immune tolerance, can develop severe liver injury that can be life-threatening. For some drugs with hepatotoxicity potential, the importance of monitoring is controversial. However, as I mentioned earlier, the anti-TB drugs such as isoniazid and bosentan for pulmonary hypertension, regular monitoring has been shown to prevent severe hepatotoxicity. Although it's important to discontinue drugs that are suspected to lead to hepatotoxicity, it is important not to stop important drug therapy if it's not absolutely necessary. There is unfortunately no firm guidance around not stopping treatment unnecessarily. This depends on clinical judgment and, of course, information about both the hepatotoxicity of the drug, which is in this very important website, LiverTox, which is in the public domain. Of course, it's important to discuss this with a hepatologist or a gastroenterologist and the responsible physician who prescribed the drug. What information do we need to gather from the beginning? We need to know if patients is suspected of DILI. When did the drug therapy start? When was it stopped? And what happened with the liver tests? And also what dose was used. We also need to know the documentation of hepatotoxicity according to LiverTox. We need at the same time to discontinue the suspected agent, exclude other potential competing etiologies such as hepatitis, A, B, C, E, cytomegalovirus, Epstein-Barr, herpes, and acute hepatitis C with HCV RNA. And we also need to exclude autoimmune hepatitis and other causes of liver disease, as alcohol-induced liver disease and or ischemic hepatitis that can lead to. This is an important differential diagnosis. Those who have concomitant jaundice are at risk of developing liver failure, and these should usually be hospitalized. And we need to check for the liver function by measuring INR, which is a marker of liver dysfunction, impaired synthetic function of the liver. Then, as I mentioned, what happened with liver tests when we stopped the implicated agents, are all serologies negative, and we need to follow the patient until liver tests are normalized. Patients who have jaundice concomitantly have approximately 10% mortality from liver failure or need for liver transplant. Those who have immunoallergic features, there might be indication for corticosteroids. Those who have a progression of jaundice, a contact should be made with a transplantation center. And those who have a contraindication of liver transplantation, such as higher age or severe comorbidity, should have a supportive care. Liver injury in cancer patients is a difficult issue because causality assessment, which is generally difficult in Delhi, can be particularly difficult in patients with malignancy who have spread disease to the liver with liver metastasis and also bone metastasis. Older type of cytotoxic chemotherapy leads mainly to direct hepatotoxicity, that is dose dependent, but other newer chemotherapy more commonly lead to idiosyncratic injury. In contrast with direct and idiosyncratic liver injury due to the chemotherapeutics, immunotherapy, the recently developed immunotherapy, can lead to immune-related adverse effects, including hepatotoxicity. This type of DILI has been called indirect hepatotoxicity, probably related to the actions of the drug rather than what the drug does, rather than by its potential toxic or idiosyncratic properties. Thus, modification of certain elements of the immune system can lead to imbalance or in immune tolerance and therefore immune-mediated hepatitis. Liver injury has been well characterized in patients with treatment with checkpoint inhibitors. These are different drugs that have revolutionized the treatment of cancer. For those who have more than grade 2, that is grade 3 or 4, more than 5 times upper limit of normal, these drugs should be stopped and monitored. If there is no improvement, they should receive corticosteroids. However, some of these patients improve spontaneously. Drugs. Not only regular monitoring has been shown to be of value, but education of patients in order to ask them to check themselves daily and discontinue treatment if they even have mild symptoms, suggestive of liver injury, and obtain liver tests when they have these symptoms, and this has been shown to reduce the severity of liver injury. Isoniazid is an important etiology of liver injury and has a very well documented hepatotoxicity. In these patients, there has been shown to be poor adherence to monitoring guidelines in many cases, and a delay in stopping after meeting the criteria for stopping has been shown to be associated with significantly more severe injury. There is an increased risk of liver injury in some patients who have chronically consumed alcohol, take other concomitant hepatotoxic drugs, potentially hepatotoxic drugs, have chronic viral hepatitis, have abnormal liver tests at baseline, or history of prior hepatitis or in pregnancy. In those who have liver injury associated with anti-TB drugs, treatment should be interrupted and modified, and recommended hospitalization in jaundice. Antiretroviral therapy, for example for HIV, can be associated with hepatotoxicity, but have much less documented hepatotoxicity than anti-TB drugs. The potential for hepatotoxicity is suggested to be increased with other concomitant conditions such as viral hepatitis, chronic viral hepatitis. Clinicians should be aware of increased risk of DLE during treatment of HIV or AIDS. Recommendation for monitoring show on labeling should be followed. Thank you very much for your attention.